Hi, my name is Charles Kahi. I'm Associate Professor of Clinical Medicine at Indiana University and the Richard Rotherbush VA Medical Center in Indianapolis, Indiana. I'll be presenting the results of our study recently published in Clinical Gastroenterology and Hepatology. Findings in the distal colorectum are not associated with proximal advanced serrated lesions. As everybody knows, colonoscopy prevents colorectal cancer via the detection and removal of precursor polyps and is currently the dominant colorectal cancer screening modality in the United States. However, colonoscopy requires considerable human and financial resources, and the need to balance these constraints with effectiveness has increased interest in strategies where colonoscopy is used selectively after initial testing with other less costly modalities. In this context, sigmoidoscopy is a very attractive option because it is technically more straightforward to perform than colonoscopy, is less burdensome both for the system and for patients, and is associated with lower risk for harm than colonoscopy. And in fact, randomized control trials and meta-analyses of these trials have shown that flexible sigmoidoscopy works. It does decrease colorectal cancer incidence and mortality, predominantly in the left colon, with variable effect on right-sided colorectal cancer. Now, the basic premise behind sigmoidoscopy-based strategies is that the risk of advanced neoplasia in the proximal colon can be predicted according to findings in the distal colon. In other words, what you find in the distal colon allows the endoscopist to adjudicate colonoscopy referrals based on the presence and characteristics of adenomas found in the left colon at sigmoidoscopy. And the studies which supported this approach were performed at a time when it was thought that the great majority of colon cancers arose from precursor conventional adenomas via the chromosomal instability pathway. In fact, even the term advanced neoplasia in this study was used to refer to lesions arising along the adenoma-carcinoma sequence. However, it is now recognized that nearly 1/3 of colon cancers arise along an alternate pathway called the serrated pathway, which is characterized by mutations in the BRAF gene, high levels of methylation of promoter CpG islands, also known as SIMPI. And in this pathway, the sessile serrated adenoma polyp, or SSAP, is the precursor lesion. Now, cancers associated with the serrated pathway tend to occur in the proximal colon, so beyond the reach of a sigmoidoscope, and their molecular signature overlaps significantly with interval cancer, those cancers which are diagnosed relatively soon after clearing endoscopic exam. While it is recognized that distal colorectal findings are a marker of advanced proximal conventional adenomatous neoplasia, this is really the principle which underlies screening sigmoidoscopy. It is not known whether the same principle applies to proximal serrated neoplasia, specifically those higher-risk serrated lesions which warrant more intensive surveillance. And this issue is of very important critical relevance for colorectal cancer strategies which employ sigmoidoscopy as the initial test and then refer patients to colonoscopy based on distal findings. So to help understand whether distal colorectal findings are predictive of advanced serrated neoplasia in the proximal colon, we analyzed data from a large group of average risk patients who had undergone screening colonoscopy by an endoscopist with high detection rates of both adenomatous and serrated polyps, combined with a review of the histology by an expert pathologist with specific interest in serrated polyps, using the World Health Organization consensus guidelines for classification of serrated polyps. We'll go over the methods briefly. This was a cross-sectional study which was conducted at the Indiana University Hospital and an associated ambulatory surgery center in Indianapolis, Indiana. We reviewed a prospectively updated electronic database for all patients who were 50 years and older and who underwent an average risk screening colonoscopy between August 2005 and April 2012 by an endoscopist with documented high adenoma and serrated polyp detection rates. Patients who underwent colonoscopy for any indication other than screening were excluded. The proximal colon was defined as cecum, ascending colon, and transverse colon. The splenic flexure and distal portions of the colon were defined as the distal colon. For the pathology review, we identified patients with at least one serrated polyp of any size proximal to the sigmoid colon, or at least one serrated polyp greater than 5 millimeters in the rectum or sigmoid colon. And these polyps were re-reviewed by the expert pathologist. The reason we excluded rectosigmoid serrated polyps who are less than 5 millimeters is that these are overwhelmingly hyperplastic and are considered benign. Pathology slides were retrieved and reviewed by the pathologist, who was also blinded to polyp anatomic location, shape, size, and the initial histopathological diagnosis. As you can see on the slide, which reviews the World Health Organization classification of serrated polyps, these are subdivided into hyperplastic polyps, which includes microvesicular hyperplastic polyps, goblet cell-rich hyperplastic polyps, and mucin-poor hyperplastic polyps. The all-important sessile serrated adenoma polyp, SSAP, the two terms SSA and SSP are synonymous, and the two subdivisions under that are SSAP without cytological dysplasia or SSAP with cytological dysplasia. And the third major category of serrated polyps is includes the traditional serrated adenoma. For the primary analysis for this study, we targeted serrated lesions which have been identified as higher risk for progression to cancer, warranting colonoscopic surveillance intervals similar to those of advanced conventional adenomas. Now, we refer to these lesions as advanced serrated lesions, or ASL. And as you see on the slide, this includes three types of lesions: SSAP-CD, so SSAP with cytological dysplasia, SSAPs that are 10 millimeters or more in size, or TSAs. And I have to emphasize, this definition is empiric and based more on consensus expert opinion than hard data, but those are the categories of serrated lesions that have been identified in screening and surveillance guidelines as higher risk, warranting more intensive surveillance. And advanced conventional adenomatous neoplasia was defined as tubular adenoma greater than 10 millimeters, containing vistulous histology, high-grade dysplasia, or cancer. Multivariate logistic regression analysis was performed to determine the age and sex-adjusted odds of advanced proximal adenomatous and serrated neoplasia with patients without distal polyps as the reference group. And we performed a secondary analysis to determine the odds of any proximal SSAP, regardless of size or presence of dysplasia, in patients with distal colorectal polyps compared to patients with no distal polyps. We'll go over the results now. The final study cohort consisted of 1,910 average risk patients. The mean age was 59.3 years, and about 54% were female. The number of patients with at least one conventional adenoma was 47.6%, and the serrated lesion detection rate was 36%. The corresponding detection rates for advanced adenomas and advanced serrated neoplasia were 7.4% and 3%, respectively. 5 cancers were diagnosed overall, 3 in the proximal colon and 2 in the distal colon. Importantly, there were 52 patients with proximal ASL and 99 patients with proximal advanced adenomatous neoplasia. Of the 52 patients with proximal advanced serrated lesions, 27, so 52%, had no distal polyps removed. Conversely, of the 99 patients with proximal advanced adenomatous neoplasia, 40% had no distal polyps. Table 3 summarizes the main study findings: odds of proximal advanced conventional adenomatous neoplasia and proximal advanced serrated lesions based on distal findings. On the left-hand side are the risk factors, distal colon finding being the one we focused on, with no polyps as the reference group. Subgroups included patients with a hyperplastic polyp in the distal colon, a non-advanced serrated lesion, so SSAP less than 10 millimeters with or without a hyperplastic polyp, patients with non-advanced adenomas with or without non-advanced serrated lesions, patients with advanced serrated lesions, and patients with advanced adenomas in the distal colon. We also looked at patient age and sex as risk factors for proximal advanced adenomatous neoplasia and proximal advanced serrated lesions. As you can see, patient age and type of distal neoplasia, except non-advanced serrated lesions, were significantly associated with proximal advanced conventional adenomatous neoplasia. And this is really in line with the literature, which shows that distal colonic findings, particularly advanced adenomas, are highly predictive of findings in the proximal colon. Conversely, when we focused on proximal advanced serrated lesions as the endpoint, only patient age was significantly associated with proximal ASL. The findings in the distal colon, regardless of their type, were relatively insensitive regarding predicting advanced serrated lesion in the proximal colon. In other words, there was no significant association between distal polyp type and proximal advanced serrated lesions. We'll move to the next table, which is essentially the secondary analysis performed looking at all proximal SSAPs based on distal findings, not focusing only on advanced serrated lesions as we define them. And in this analysis, only the presence of a distal SSAP was significantly associated with a proximal SSAP. Granted, this sub-analysis is somewhat limited by the small subgroup sizes. There were no significant associations with age or sex. So we conclude from the study that the findings at flexible sigmoidoscopy that traditionally serve as indications for colonoscopy, that is conventional adenomas, are likely to be ineffective for the detection of proximal advanced serrated lesions. We observed this in the study, and we also found that most patients with proximal advanced serrated lesions have no distal polyps. These two observations favor screening colonoscopy over sigmoidoscopy, especially in the elderly. The observation that non-advanced distal SSAPs are associated with any proximal SSAP warrants further study. Thank you.